We're happy to have all of the Equity Initiative Fellows with us to discuss the new books, Why People Get Sick, which will be available today as well, and also just a conversation on public health. Today we have with us Kun Suebpong, an Equity Initiative Fellow, who will be our moderator and will be making the introduction for the rest of the speaker. I hope this is a fruitful conversation and enjoy.
Thank you so much. So today, thank you for joining us for this book launch event. And we have the three authors or editors, Dr. Clive, Putri, Thierry, and we have Dr. Piya as well. Maybe we can have each of you introduce yourself a little bit, and then we can go into the program. Is that good?
Yeah. Hi, good afternoon, everyone. Very nice to meet you all here on a Friday afternoon. I know it's been a long week, and probably you coming here. Hopefully, it's a very rewarding session for you. Thank you so much for supporting this launch. I'm Clive. I'm a public health physician. I'm based in Singapore. So this is a project that Putri, TV, and myself took 2 years to bring the book to fruition. And we're very happy here to have Suebpong and Junction and Piya help us to come here and launch it together with you. Thank you very much.
Thank you everyone for being here. Likewise, I know it's been a long day, maybe. I was so grateful just to give the time to be here. My name is Putri. I'm from Indonesia, but currently living and working in the Netherlands. I'm part of the same fellowship. My background is a medical doctor. I did public health training as well, and at the moment working in spaces in between health, feminist justice, decolonization, and social justice issue. Thank you.
Thank you. Good evening as well. My name is Piya. Previously, I was a lecturer at Chulalongkorn University in the medical school, and also at the National Health Foundation as the Secretary General. But those two I already left those two and have more time to myself. Right now, I'm still doing consultancy as a senior consultant for the China Medical Board Foundation, which is an American foundation with a Chinese name, but work in Southeast Asia and China on health and health equity. And very glad, very honored to have a chance to be with all of you here.
I'm the sideline speaker. So my name is Thierry. I'm from Myanmar, and I'm also one of the fellow. And really fortunate to work together with Clive and Putri on this book project. My background is not any medical background. I'm the researcher in the media at large, and I also do the creative advocacy. So I won't be speaking, but I will be joining for the question and answer session, and so that we can have an interactive dialogue. Thank you very much for coming today.
Okay, so today we'll have Dr. Piya talk a little bit about health equity and why this book is important.
Thank you. Well, I was trying to ask with them. First of all, I have to confess that I didn't have a chance to read the book. It just came with Clive, who was stuck in the traffic for a while. But definitely, I think this is an issue that many of you already chose to come here. That's probably something important. They said you should talk a little bit of health equity. I think you probably know more about health equity than myself. I could share a little bit that my background as a medical doctor in the past, and decided not to do just medical practice or a physician, but work more in what I would call health policy, health system, and others. So I felt that initially as a medical doctor, we really much interest about why people get sick. And we very much focus on the germs, no? Disease from germs. And lately there's disease from behavior. We thought we knew a lot, but actually after having a chance over the past 1, 2, 3 decades, I feel that what I learned in medical school was so small, so little compared to what we are thinking about what make people sick, because germs or even personal behavior is just a very small part of the equation. And we shouldn't just look at why people get sick, because otherwise we'll focus on people who come to the hospitals or come to the clinics. Many of people who get ill or sick don't come. And there are actually also many others who don't have good health and didn't have access and couldn't really experience. One big eye-opening opportunity is the chance to work for this CMB Foundation I mentioned to you. And we had a program on health equity, and one of the very special program is called Equity Initiative, which is funded by CMB and also co-funded with the Atlantic Philanthropies. Is intended to be 20 years, bringing every year 20 to 30 fellows together from ASEAN countries and China. And they took 6 trips in the past. I don't know how much now. I left about 2 years now, but 6 trips, each trip about 1 week together, going to Asia and maybe 1, 2 trips globally to the US or UK or South Africa to basically have experiential learning, to go through the situation where people are experiencing what we call health issues or other determinants of health issues. And they learn through their cohorts. They learn with speakers. They learn from projects that people are doing. And they also do some project themselves. And this is one of the projects that our EI fellow have implemented and come out as a book. We probably will hear more from them. Why do they do this book? What made them focus on this topic? But I would like to share a little bit from my experience with the Equity Initiative during the experiential learning. One thing that really stuck with me was in my second year of the fellowship. I was the program director, co-director, so I had to go with them. And there was one session we call Asia Trek. We took them to a country, and I wouldn't say the name of the country. I don't want to make you know which country. But it was a good learning experience. We took them to the urban slum, like the place where people really have difficulties, look at what they experience, but also look at the health service and others that they had there and the effort to try to change what they do. But we also expose them to other efforts like the what do you call economic program to help people to have their earnings and others. But one thing that stuck me is the end of the program. Everyone finished. We had dinner already done. And I decided, well, as a Thai, and after a long week of working so hard, I saw a sign. It say, Nuat Pan Thai, a Thai massage. I need myself to be hurt and twisted. So at the end of that week, I decided, okay, I'm going there. But what stuck with me the most was on the way back. I had to take a taxi back to the hotel. It's not so far, but it's in the middle of the big cities. So I was sitting in the passenger seat, going back on the street. And then I realized one thing. After the car passed, there was a woman, more like a girl, looked probably around 12, 13, sitting alone in the middle of the road, no? In the, what you call the divider between the two sides of the road. And the taxi almost slowed to the stop to the traffic light. Initially, I saw just her sitting there, looked like probably 12 or 13, very thin, and looked like she is almost crying or something like that. So I felt, so what's going on? What's wrong? Why is she sitting there alone, very thin girl in the middle in the evening, almost 7 or 8 p.m., no? And then when the red light became green, the taxi started to move. It shocked me when I saw it's not just her actually. There was a small baby on her shoulder. very small, probably a few months. I was numbed. I didn't know what to say or feel until taxi dropped me at the hotel, and I went back to my hotel room. And I tried to understand and search about this children in the middle of the street have no home. And it's not just one, it's actually so many in that area. I was like crying, but basically try to think what we can do. And it also, I mean, got me to think more about what we think about health. What do we mean by health? What do they have to see? What do they have to expose to, right? And what the level of strength or vulnerability that they have. And a lot of these are not just for these kids or women or children, but actually in many aspects of our lives, there are a lot of people, there are a lot of communities, there are also many other dimensions that I will not probably have to tell you, but maybe from the story, from the book, you will hear more. And at the end, hopefully we can have some discussion about what do we mean by health equity in Southeast Asia and what we can do together or separately to make this thing better. So I would like to stop here. Thank you.
Okay. So thanks Piya, and I'll go next. And do I have the clicker? Okay. Thank you. Yeah. Oh no, it's okay. It's okay. It's easy. It's easy. Yeah. So when I was 7 years old, okay. So yeah. Okay. Yeah, but then it's like I think okay. Okay, thanks. Okay. So I want to share a story when I was when I was 7 years old in Singapore. 7 years old is when we start primary school. Right. So both my parents were working, and I was actually living with my grandmother and great grandmother. So school at that time was, we had a recess time, and I was given 50 cents for my recess. So 50 cents would be about 10 baht, right? And at that point in time, the choices were very simple. 50 cents, you can buy a big bowl of noodles, or you can buy a small bowl of noodles, and 20 cents, you go and buy a curry puff or a drink, right? So every day I would finish spending my 50 cents, and there was no savings. There was no chance for savings because, you just spend that 50 cents away. And that shaped my mentality a lot, in that, I only had enough for myself. I only had enough for today, right? There wasn't much savings available. Next slide. Okay. Is that, can I do it myself? Okay, great. Thank you so much. Yeah, so, okay. So this was around, my primary school was around like 1990s. And one of the key events that happened around 1990s was that there was a Rwanda genocide. And because of that, there was a lot of famine in the country. So when I was young, I remembered seeing a lot of pictures of African children, very skinny, very emaciated. And there was a lot of donation drives asking for people to donate to help the needy in Africa. Your $1 can buy a meal for this person for 2 days. So there was a lot of that photos going around, and a lot of that donation drive going around. But I had nothing to give. And I think it kind of shaped your mentality when you kind of had to pass the envelope, right? And you just, okay, without putting anything, you just pass it on. right? I think it was a bit of a dilemma, right? Do I give and then not have something to eat at recess, or do I just pass on the envelope? And I also remembered my parents telling me, don't try to help people. We don't have a lot to give, right? Those donation to charity, churches, let the rich people do it. So that shaped a lot of my mentality. And I think the first few times just passing away the envelope was a bit of a dilemma. You felt a little bit bad because you were not able to save some people in Africa. But after you pass on the envelope a while, it becomes easier. Right? You kind of numb yourself a little bit. And after a while, it becomes a habit. Means you just don't give anymore. So looking back, I think what happened was that I built walls around myself. Right? I built walls around my heart because seeing all those photos, normally, like Piya, right? You see something bad, you feel emotional, you feel a bit hurt, you want to cry. But after you see a lot of it and you can't do anything about it, it's a very natural mechanism to then build walls around your heart. And I think I had that because I didn't have a lot to give. And my parents also say, giving, let the rich people do it. So I built walls around my heart. And maybe I ask, what's your name? Sam. What do walls do? Okay. Yeah. So they sort of prevent bad things from coming in, and they are meant to protect. But I think walls also isolate. Walls also isolate. So, and the funny thing about walls is that once you've been inside the walls for a while, it also gets a bit comfortable. Right? So, what happened over time was that, I had these walls around my heart, and it protected me, but it also isolated me, and it became comfortable, such that I think it became normal. It became normal not to feel. But something was going to break, right? Because this was not a normal way to live. And I think it broke when I got married, and it broke when I had kids, because I didn't know how to give, even with my wife and with my kids. It took me, I think, 3 years before I could really connect with my kid. Like, the first years, like, okay, they don't talk, right? So you're like, oh, it's just a thing. Then when 2 years old, 3 years old, they start to talk, and then you're like, oh no, yeah. It was very hard for me to connect because I had these walls around me. But it needed to break down. It needed to break down before I could feel fully human, before I could connect as a husband, as a father. And it just reminded me that, humans, we are made for connection, right? Okay, I mean, we are in this arts place, so I have to say that Yayoi also said something along the same lines, like we were made for love, right? But I kind of, love is a bit of a heavy word for me, so I say we were made for connection. What do we connect with? We connect with our families, we connect with our communities, we connect with groups. And when you have walls around your heart, you can't make the connection. Yeah. So one thing I realized that helped me understand this better was that when we give things, it's not just about money. It's much, much, much more than money. We give our time, we give our knowledge, we give our skills. And I realized that even if I wasn't able to give money, I was able to give other resources, other things that were important to me, right? My time, my money, my effort, my attention, right? And I think this helped me to, be a better person, right? Be a better person, be a better husband, be a better father. And I think so on this, we also have to ask, who do we give it to? Who do we give it to? We give it to our families, but do we also give it to a group, right? What are the groups that we want to give our time, energy, effort to? And it comes to this question that I ask myself, what moves you? What moves you, right? What makes you angry? What makes you sad? What makes you hopeful, right? So when Piya saw the little girl in the middle of the street holding a baby, I think that made him sad to the point of, wanting to cry and going back to the hotel and feeling very down. So what moves you? What moves you? Like, is it, and for different people, it's going to be different, right? Putri, we will find out more from her what she stands for, but she is very moved by gender-related issues, gender inequalities, right? And TV, she is from Myanmar, so when she sees the airstrikes happening and people dying, she is very upset and she shares it with us, right? So, okay. So, right. Yeah. So I think what moves you for me is something that I also am discovering, because when I joined this equity initiative program, there was I was in a way of trying to discover myself, right? So I am still having some walls around my heart. So even when I am looking at some of these inequities, I still hold a bit of distance. But when I partnered with TV and Putri on this program, we realized that why we wanted to do this project, right, of putting together stories of people from Asia, writing about people from Asia. I think the world today is quite messy, right? The world today is quite messy, and 20 years ago, 30 years ago, we were looking towards the West, right? Towards Europe, towards US for some form of leadership or guidance. But today, the world is quite messy. And Asia, I feel, is actually a good place to be. And we are stepping up a little bit more to the leadership plate. So when Chuck Finney, one of the philanthropists who donated for CMB Foundation, he also believed in the strength of Asia and was able to set aside a certain amount of his fortune to help us to create this equity initiative program. And then he believed Asia was able to determine its own fate and wanted to use this program to groom leaders to step up to the plate. So why we did what we did was really we wanted Asian stories, Asian voices for Asia and by Asia. So we wanted our own narratives on health equity. Health equity sounds like a Western concept, and the way it's explained, the professors who are explaining it sounds very Western, but it really isn't. It's really a concept that belongs to the whole of humanity. And I believe that the stories that come out from Asia would be very different from the stories that come out from the US or Australia. And that's what we wanted to do, coming up with our own narratives and our own stories that can be told by our own people. Yeah. But thinking about inequities can be very paralyzing, right? Because it's so vast. There's so many root causes. There's so many factors. But I struggle with it. I struggle with it because I'm like, oh, I'm only a drop in the ocean. What can I do? But I realized that there will always be inequity, right? So if we are paralyzed by the fact that, or we are trying to solve a problem, no, this problem will not go away. This is not a problem that can go away, but it's a problem that can be managed. It's a problem that we can do something about. It will never be solved, right? There will always be the poor, there will always be disparities, there will always be inequities. But how we react to it, that's what's going to define us, that's what's going to define our narratives, and that's going to be something that we can hold on to. So coming back, like, what are the things that moves you? That is what the stories kind of help to encapsulate, because the stories tells of people with disabilities, people who have been marginalized because of their race, gender, or even just because of where they have been born, right? So the stories, I hope when you read them, they will also move you. So we brought some copies over, and we'll be happy to have you buy them. Just to say that the monies that we collect today are going to be donated, right? So it will be for a good cause. Yeah. So this was something that was in the foreword of our book, right? And I wanted to end with that, because what we are trying to do here is to build awareness and knowledge. Build awareness of a knowledge that of an issue that's a little bit hard to explain, a little bit hard to discuss, but through those stories, through a safe space, through a stories written about our stories written, it can create a safe space for discussion, and that's what we hope it can be. So I'll end off with this phrase to say that a candle loses nothing by lighting another candle. Thank you very much.
Thank you, Clive. Putri, would you like to say something about the work and
maybe before, because I also don't want to speak too much. I just want to ask a question actually to the audience. Like Piya said, is any one of you also coming from the traditional health sector, like a doctor, a nurse, a public health expert, or, if you don't mind? Yeah, because and is any one of you, maybe as a client or a community member, have you felt like frustrated by the medical system or the health system where you are? Including your own, the system you are in, right? So, and last question, when you see the title of the book, Why People Get Sick, what do you think and what do you imagine it would be? If anyone wants to share a bit.
The issue of equity and yeah, so I guess why people get sick. Okay, that's the basis of the medical profession, right, or health professions. But then, and some more than others, it's not just about a germ or a virus. It's also about the context and about the person's own background and so on. So I just thought that was quite clever.
Yes. One more, maybe? Yes, Fabio.
Oh, sorry.
I'm not sure if I heard everything of you said, but Paulina, I think also why some people get sicker than others, even within the same community, on the same group. Yeah.
Yes. So I also have that kind of like being from the traditional medical sector, we are trained a certain way, or at least I'm trained a certain way. And most is like what Piya has shared, but also this almost like an obsession of individual behavior. For example, I'm from Indonesia. We have a huge problem of smoking. We're one of the most burdened country in the world by smoking. And it's very easy when you have a client with chronic lung diseases, or a father who keeps smoking when the children have pneumonia or like lung infection and stuff like that, it's very easy to get angry with that individual. But then Indonesia is also very burdened with the tobacco industry. And many research has proven that tobacco industry is targeting the poor, targeting the young people with marketing strategy that is about that, you know. So, and then I also have personal experience when, so I used to practice for like 8 years or something as a GP. And then I decided to move to public health for a certain pursuit. So I used to work in a remote island in Indonesia, and maybe this is not common, not like a secret, but abortion in Indonesia is criminalized, heavily criminalized. And then I have a young client in high school, and this is like remote island. You have to go by boat if you have to go to hospital. And then this person came to me basically late, 2 months in their period, and then like that place have a history of child marriage when pregnancy happens, or they just drop out of school, right? So I remember the anger I feel because abortion is criminalized. So, and nobody ever taught me how to do it because it was criminalized. So then I remember the anger, the feeling of how do you say limitation of what you can do. Sorry. Sorry, this is like a story that's sort of like very hard to talk about. So I was still young. I think that was in the first 2 years of my medical career. And I remember, so when Thierry said that she doesn't come from a medical field, I actually am really grateful to feminist activists and like all the social justice activists in my hometown, because it's very easy also for medical doctors in Indonesia to judge abortion because we are, you know, the criminalization brainwash us all. And it's very easy to judge the person who wants an abortion. And yeah, I remember that is the start of my journey into public health. That is why I decided to do public health, because I feel like there's so little that you can do as a medical doctor sitting in the room. And I have also clients with like domestic violence survivors, all those people who you can treat the wound, you cannot treat the cause. And I think that is why the title of this book is Why People Get Sick. Because I feel like our training in the traditional health sector is so limited. When you do public health, you got introduced to a social determinants of health. That's how you call it. But I also feel like it doesn't really emphasize on how all these determinants of health are very power-ridden. So like, the gender inequity that fits into abortion stigma, that fits into queerphobia, and then the structural impoverishment of people. And then like in some region, the racism, the conflict, you know, when countries have conflict, it doesn't happen by itself. It has political determinants as well. The thing that, for example, a country decided to cut on the health funding, and then that caused people to have to pay more out of pocket, and that caused them not to get treatment and everything like that. That is all power-ridden, and there is something missing in how we talk about health and social determinants of health. We ignore this part, that everything is about power, and power is political, and resource is political. And I think that is sort of like something that I really would like to introduce, especially from the lens of someone within the health sector who are like traditionally trained. I think we need to think differently. That is why I'm grateful for people in this like social justice activism, because without them, I will not be exposed to this kind of thinking, and many still are not. So yeah, I think that is the question of why people get sick, and some more than others. And even some, like Fabio said, some inside the same community have some intersecting thing that oppress them in ways that's different from others. I think we just need to go beyond and really look at health as a social justice issue, not just a depoliticized sector, you know, because it is political. So yeah, that's just what I want to say.
Thank you, Putri. Thank you. It actually touched me about what you're saying, because I've also been in my journey of understanding a little bit more about why people get sick, or why myself get sick. And I think coming from a middle class, well-to-do, and reading this book, it was really eye-opening. And I feel like there's more that we all can do. And I think, like you say, it is about social justice. It's about creating a social awareness, a social movement, and then using the elements that we have, whether it's knowledge of the system, working in the public health, or even as a international NGO or third party, to really bring the topic out to be discussed and addressed. So I'd like to ask if Thierry would like to contribute something to this discussion, and it's up to you. And if not, we'll open up to the floor as well. Okay, sure. Okay. So anyone in the audience would like to make some comment, have a discussion, maybe, oh, yes.
Check. Hi, everyone. Thank you so much. My name is Agatha. I'm originally from Indonesia, but I work and live here. I work at the organization called Youth Lead. It's a regional network for young key population in HIV and SRHR issues. I want to ask a question to the speakers. So because people get sick all the time, are there any identifiable patterns on how the government in Southeast Asia responding to the public health problems that is being discussed, or at least mentioned in this book? Oh, by the way, my pronouns are Deshi. Happy Pride. Thank you.
Okay. Yeah, I can only speak of my own, actually. Maybe you follow the politics of Indonesia, maybe you don't, but we are currently regressing in terms of democracy and civil spaces. And we do have things that I'm proud of. For example, our national health insurance system. I really think it's necessary. It's about time. It should not be wiped out. It makes a lot of difference, including for my own family and parents. But the way I see it, this is why also I feel civil society needs to also demand the rights to health from a social justice lens. And at least in Indonesia, when it comes to the gender space, SRSR, we do have that kind of, what do you say, sort of like a coalition. Maybe Agatha would also be able to explain a bit more on kind of like this awareness of, okay, this is like a justice issue because it's connected with gender and the HIV activism. But in other sectors, not so much, I feel. And we have a divide between movement on social justice and the people who work in the health sector because of this problem, according to me, because of this problem of depoliticization as well. And the rights to health needs to be treated as such because we need to demand our government to also act on it as the commitment of a duty bearer. So things like we just cut our health funding, if I'm not mistaken. It has already like been low compared to the standard. It has just been cut again. And then there are conversations about privatization of the health sector, relying more on the private sector. So, and the way I see it, and it's very different from Thailand, from what I know. I think in my master's thesis, I also look into Thailand health sector, and I'm amazed by how it's very rural oriented, and it's always been like that. Indonesia we also have that kind of like rural healthcare system, but it's always been underfunded. It's not strong enough. We have a lot of issues on equity of access, and I think there's a tendency for our government, at least in Indonesia, to make it more about capital and resource rather than how you treat access to health as resources. And yeah, I don't know how to solve it, because I think all of us are a bit like, oh damn, like this is not going the right way. But I think, at least for me, how Thailand is kind of like strengthening its healthcare system can be an inspiration as well. I think you folks do something really right in terms of really trying to make it equitable as much as possible. And how do I say? I also think that this is also linked generally to civil space, democracy, and all those things, because politically it's a line, you know, like this lens of making health as a thing of like how you divide resources equitably within people, you know. And I think you have a pattern as well, like if a government is the more authoritarian a government is, usually the least of access to health and health equity that you have. And I don't think it's a pattern. It's not something that's just coming out of chance, you know. So yeah, that's my thing.
Thanks, Putri. Thanks, Agatha, for the question. So I think when government in Southeast Asia, we look at them, I want to be very honest to say that ministries of health are usually quite underfunded. So a lot of them may not know of the issue, right? So I would classify as governments or ministries of health that actually do not actively look at health disparities, right? Because they don't have the data, they don't have the analytics power, they don't have the resources to look at them. So I think in those cases, it's important for civil society to raise their hands and say, look, there is a problem here, right? These people in the rural areas of this country are not getting the medical services that they need. And through your mayors, through your elected councillor, make that a bit more apparent. But there are countries that also do look at it, right? That means they do know. And that is where we can look at them to say, if you know, are you doing something about it? Right? Are you talking about it? So in Singapore, the government is not very good at talking about it, right? Because of some of the things are sensitive along racial lines, right? So like doctors, we would know that like breast cancer screening, the Malay women tend to go a bit later, and then when they get diagnosed, it's usually a bit later, their breast cancer. We also know that Indian men have a higher chance of heart attack, right? So I am just being quite open to say that we sometimes don't have the language or maturity to speak openly, but the government is doing something about it. So I think we can classify in 3 ways. One is, does the government know? Right? If the government doesn't know, then it's our job or civil society to make it known to them. And if they know, are they doing something about it? Right? Sometimes they are doing something, but they are not talking, right? Because it may be sensitive. So if they are doing something about it, I would say, okay, no, good job. But I think the really enlightened ones are the ones that are doing something about it and have the maturity to be able to come out and say it, and trust the populace to be mature enough to say that, okay, let's be open and say that certain racial diets cause you to have diabetes or heart disease earlier. Yeah, thank you.
If I may, I'm from Thailand, and I think me personally, and I think a lot of Thais, we're very grateful that we have the 30 baht and we can take care of any disease, OPD, IPD. I think we're very blessed to have this, and I think it's a great safety net. I still feel that the leadership of the resources, the payer, right, the National Health Security Office can still do a lot more in terms of preventive health, promotion, proactive health, lifestyle interventions. And I don't think it's just a Ministry of Health or Ministry of Finance issue. I think there is the Ministry of Interior, who also has a lot of budget in each of the provincial districts that can also be activated in terms of educating the people, addressing some of these social determinants of health, as well as lifestyle choices. So I guess as an insider and a stakeholder, I see room for improvement. But looking from the outside and comparing with many countries as well as developed countries, I think we're doing quite well.
Yeah. So I wish I could share like this, but coming from Myanmar, I'm totally this side because you know, in the region, Myanmar, it's very different. And you were saying like the government is doing this and a lot of other countries, yeah, there are room of improvement and all this. But for Myanmar, at the moment, technically we don't have legitimized government. But those people who are holding in power, we are under the Myanmar military coup. So at the moment, the power is in the junta. They are controlling, well, not controlling, they are in the country. So I don't know if you're really aware of the meme, like, you know, don't be the part of the problem, be the whole of it. So they are the whole of it. And so our major public health problems coming from the military. So we are not even talking about access to health or anything. We are even like fighting for our life. We don't even have the rights to life. And after the Myanmar military coup in 2021, since 2021, we have the health sector is collapsed from because there was a coup and also the protest nonviolence movement against the Myanmar military, Myanmar coup and all this. And then the Myanmar military did the punitive measure against the medical sector. So that leads a lot of the medical professional going flee into the jungles, and we have our own system in the jungle in the fighting. But what happened was it's the military is doing the targeted airstrikes and artillery shelling and all other attack targeted to the medical facility and arresting, killing, and everything that is medical related, but it is also politicized. And we can't even talk about any of these like policy change and anything. Meanwhile, we're just like really trying really hard, even to survive, even to breathe. And so hopefully one day Myanmar will be on the lead to talk about, to advocate to our government to improve the health sector. But at the moment, we are just totally isolated from the region. And yeah, it's because they're the main reason why we have a public health issue.
Have you been inspired by historical role models, maybe? Because the issue itself, especially from a social point of view, is not a new one. I remember, for instance, from last century, the 60s in South America, you have Ivan Illich, to put a name, was very aware of that society makes people sick. And even contemporary one in Canada, that is Gabor Mate. He wrote a book, The Myth of Normal, and he talks about toxic culture. So there are more people who are busy with this issue, and I'm asking if you are inspired by some of those people, or maybe in the region here itself, in your Asia, from Asian culture.
Thank you. And when you say culture, you're talking about national and indigenous identities. Is that what you understand?
Gabamate, he had an example as in the lab that you have, this thing to, the petri dish, and he called this the culture. And within this culture, something happens. Yes. So we as persons, we are embedded in wherever we live. Yes. If I, as a Westerner over here in Thailand, are confronted with the culture here. And when I'm in the Netherlands, where I'm from, then I'm there in another culture. We have another medical system and another point of view, how to treat illnesses and so on. Okay.
Thank you for clarifying. Before I pass on to the panelists, but personally, I'm exploring about can private sector and organizations play a part in the health and well-being of people as well, both their employees and maybe the family members of the employees. And I think as we're investigating this, a lot of it's about the corporate culture, the values and the actions of the leaders, and also what they define as their own purpose as a large company, as well as individual leaders. And we've seen there are books talking about this, like the Healing Organization. And they've talked about how the role of private sector and creating the right culture in the company will entail having more sharing of power, will also entail caring of the people, both the mental, the physical, and the emotional well-being. Yeah. So those are my thoughts.
Okay. Thank you so much. I didn't get your name, sorry. Your name? Francois. Okay, thank you very much, Francois, for the question. So around whether there are any role models. So for me, I'm a student of health systems. So I look at how health systems in the region evolve. And if I can share one of those early decisions about Singapore's health system was that we wanted to have basic primary health care available to everyone. So the British left behind a polyclinic system, which worked. So what we did in the 1960s was to just extend it and build on it. But what Mr. Lee Kuan Yew, our founding prime minister, then did was he said that it cannot be free, because he lived in the UK and he got a lot of free services. He enjoyed it, but he said, oh, this is not sustainable. So when he was prime minister and when Singapore gained its independence, he said that we're going to impose a co-payment, right? 50 cents for you to see the doctor and get all medicines at the polyclinic. And a bit less known was, if you come on a Saturday, it's $1. So this was the kind of, encourage people to come on weekdays and only weekends if you are really sick, right? Why I'm sharing this story is because health systems reflect the value of the political systems and the ideology. And at that point in time, it was, we're a poor country. So, and because he felt, his experience in the UK led him to say that, there might be a risk of overconsumption as everything was free. So he made a very clear choice. But I think what I respected about the choice was that he explained it. Right? He said, I am deciding and I take responsibility for it. I'm deciding that we put a 50% charge, right? And that is because of ABC, right? We don't want you to overconsume. We want to make sure that you don't take your medicines and throw them away. You paid for something, you're more likely to take care of it. So he did take the effort to explain it and I think that is what sound public policy should do. Thank you.
So like when we were from different background, when we met at this fellowship, like as I said, I'm not from the medical background, right? So originally, like when we got with this name, like why people get sick, actually, I for me, I feel like, I have nothing to really contribute because I'm not from the medical background. And so I think because of the fellowship, like you said, there are people who have written about this kind of like stories and the model. Somebody must have already thought about it, already have done it. Therefore, like, it has been passing down and we have been the knowledge has been carried. But for me, I think for Southeast Asia, at least for myself or among my friends in Myanmar, this is a very it's a very new concept and for us to discuss, because when I go to this health fellowship, a lot of my friends make jokes about to me like, why are you going to the doctor's fellowship? You're not a doctor. Why? And some friends call it like Doctor Without Border Fellowship. It's just a joke. It's not. But yeah, so this is for us. It just for personally why what made me inspired to be part of this book is that I want to share these issues to my own community so that we can talk about the social issue that we've been facing every day from the health language in a way to make it more intersectional and trying to explore. So, but to do that, a lot of my friends, a lot of my community, people that I work with are storyteller, also social justice activists. They're not health people. So they're not academic. So if we just do this kind of bit language and bit health language and a lot of intersectionality and all the academic language, it may not necessarily resonate to them. So therefore I'm from the storyteller perspective. So we will bring in different skill set. And so we're trying to bring this story within the region. Like Clive said, we want to have a narrative, like Southeast Asian narrative. We like to also share our story in our own way and also trying to do this kind of avoiding the single storytelling. Like usually people tell the story about social injustice. It is just like, oh, poor little people or starving children and all this. We do not want to paint that. We want to do is beyond. And there are lots, if you read the story in our book, some of them are they were talking about the social justice issue, injustice issue that they are facing, but at the same time, they are not stopping there. Like they are trying to, they have agency in there if you look at in the story. So we're trying to bring different perspective, but in a way, the power analysis, more relevant to Southeast Asian power structure, not to, I think that power structure analysis in Southeast Asia context, I think it's very important. So I think we're trying to draw from that, and like especially Putri from, she bring a lot of this knowledge on the intersectionality. So this book, yeah, we have learned like basic concept. Yeah, there's some start rooted somewhere, but it will be unique just for Southeast Asia and China. It's beyond Southeast Asia.
For me, I think I really owe a lot to many grassroots activists and community people that has taught me a lot. Health is a very close-off sector. It's almost like it's elite and exclusive, and it's a rare chance for us coming from this kind of like ivory tower type of sector to be able to understand a deeper meaning of social injustice. So I think there is a lot of like named and unnamed also community activists that I learned from my own hometown. I'm from the capital of a province called West Java in Indonesia. When I was still studying, we have quite a vibrant youth activists, feminists, queer activists, and it's hard to be feminist queer activists in Indonesia because we are queerphobic. So, and also like, I see a lot of like, okay, I do not really want to use the word resilience because sometimes it's being backfired, but in terms of like, I really admire, like Thierry said, they have a lot of agencies and so many things that the government doesn't do, they do for themselves and for their communities. So that is what really teaches me of how to do this work in the places that I'm privileged to be in. And I also want to bring one particular issue that is very relevant for our health sector globally these days. I'm lucky enough to work alongside these people specifically in the it's IFE community activism. Why I bring this? Because we are in the middle of a lot of global health funding cut. And I saw firsthand how that hurts people. And I also saw a lot of how community work are trying to push back and trying to advocate that community is really need to be funded. So I want to bring this message because the same people are the people who are my teachers. And when you talk about intersectionality and social justice, they are the one who are the most knowledgeable. And at the end of the day, for me, it's just these people who are like really, really influence how I think about my own sector. So.
Thank you. Yes.
Yes, I do have a question. So I would like to also bring attention to the book and the stories in the book. This book is also a collection of different stories to talk through different narratives. And I noticed we have some illustration up on the walls beside you as well. So if I could ask maybe a bit more on the process of collecting all these stories and all these illustration that you put together in the 2 years of work that you bring together for this book.
Thank you. And if I may add, maybe from each one of you, which was the most touching story and why?
Yes. So collecting the stories was, I would say, not that difficult, surprisingly. We worked through some of our fellows and the networks of our fellows. So we had people who were willing to contribute. But the stories needed quite a bit of guidance and editing because they were very raw, right? But this was the fun part, right? Because we also didn't want to cut out the natural voice. So if you read the stories, you find that we tried our best to preserve the natural voice. That means one of the story, Amy, was an Indonesian lady who married a Singaporean man and is living in Singapore. But because she is still a foreign wife status, she doesn't receive some of the healthcare subsidies. And then she has to work and earn money, but it's hard for her to get long-term work, right? So if you read that story, you find that we managed to preserve some of the authentic voice in that the English is not perfect, but then you can actually hear it from her perspective. And we try to encourage the authors to write in the first person perspective. So some of them had to pivot their stories to make it more like a first person. And that's because when we found that when we read in the first person, it's a lot more powerful. It's a lot more powerful. And I would say that that story touched me a lot because it opened my eyes to something that I, being in Singapore, was quite invisible to. Like there were a lot of foreign people in Singapore, right? Foreign workers on different type of entry passes, and also foreign wives, foreign spouses. But I, in my little ivory tower, have not opened my eyes to them. So that story touched me a lot. With regards to the illustrations, I want to really credit Putri and TV for coming out with this great idea of getting illustrators from the region. So I'll let them also share their story and how they got onto this idea of illustrations.
So as a team, we thought that it would be good to visually visual. I'm also creative. I work in creative advocacy work, and also we know, recently I've been working a lot with the visual storytelling. So when Putri and Clive as a team, we would be like, okay, let's do some medium. Let's enhance rather than the written things, because sometimes we also notice there's a limitation of our process as well, because a lot of all the story are in English, so that have to exclude the people who cannot write in English or who cannot read English. So we trying to, this is also equity issue itself, which we also aware, but for the sake of the general, so this is the first step and we have to do it. So to be one step closer to be the equitable in our process of storytelling, we also wanted to include the the picture, because the picture also tell, and even people who may have difficulty reading or other form, they can also resonate with it. So the process is that we work with the emerging artists in the region, because these are the story from the region, and we want the illustrator to be the artist in the region. Especially younger people, we want them to share it. So the way we do it, we don't commission them to just like draw something. We give them the story. They read it, and it is their interpretation of the story. So we give them the artistic freedom over how they want to portray it. What does it mean to them? And it's each of them, the artist will give us the story, like what is the meaning behind, even the using of color, even this like the one over there is a Rohingya one, that like the way they are facing, what does the one to the very left, very right, like it's about the AIDS worker, and they're working towards the sunlight, while a lot of Rohingya people in the refugee camps who cannot leave, they will be in the darker side. So that is how the artists interpret the reading. So every process, it's everybody involved. So these are not just commissioned artists; they are also part of the storytelling. So we have this story, and then this is like an expansion of the story, interpretation of the story into another. So when you read the story, when you look at the illustration, there will be another form. I think that is a beauty of like, interpretation of the wink upon wink upon wink idea. So that's a process.
Yes, for me, I think personally, because I'm currently a migrant, I live and work in the Netherlands. The stories about migration is the one that also touches me the most. So the Rohingya one, and then the internally displaced people in Myanmar because of the conflict, the war. And then I think there are two about migration, and the one with in Singapore, because the woman was Indonesian. And during our induction year in our fellowship, we have a trip to Singapore, and then we talk a lot about migrant health in Singapore, something that so Indonesia sent a lot of migrant workers outside, right? So that is something that I am privileged also because of the class privilege. But also that one, if you see the one dotted in red, that comes from Indonesia, about a woman with multiple chronic diseases who the health system couldn't handle. And then that also have something to do with her being sexually assaulted. And so it's a complex story to see that how there are many things that makes you get forgotten in the health system. So yeah, and I think some of these illustrators also share the lived experience of the stories, which also brings this perspective of we need to tell our stories out there. So yeah.
Maybe one last question or reflection.
Hello, thank you. I'm Piya. I'm a PhD candidate at the Australian National University, and I'm here a visiting researcher. And I think this book is very timely because the pandemic also showed us how health inequity was very palpable in society. And I wonder, how would you describe the situation of access during the pandemic, especially across the populations that are represented in the story? Is there any particular like barrier that they face that like some kind of reflection, that you can share? Because also in the global health, we just had a pandemic agreement, and one of the like the impact is access to medical countermeasure like PTD, vaccine, therapeutics, and diagnostics. So is there any reflections how this people, so these stories reflect the barriers that they had, especially it was published in 2024. If you have this during the process of writing this book. Thank you.
Thank you very much. Tian, is it? Yeah, thank you so much for your question. So I'll start first and give my friends some thinking time. In Singapore, when the pandemic struck, the first group that it struck was actually the migrant workers working in construction, shipbuilding, and most of the migrant workers were housed in dormitories. So what happened was the dormitories tend to be a bit crowded, and also the medical care in dormitories was very suboptimal, because if a migrant worker was sick and he needed to see the doctor, he'll miss a day's work, right? So different companies handle that differently, but what it means is that he needs to take a bus from the dormitory to the clinic, and then pay for the consultation, and then come back and miss a day's work. So many people delay their health-seeking behavior even when they're sick. And that came up really apparent during COVID, because a lot of people were sick, but nobody was going to see a doctor. So it just spread around, right? What happened was that it really shone a light on how we have neglected this group. Not something we're proud of, but I'm happy to say that after that, the government, when Putri and TV visited Singapore, they saw that it was an issue, but the government did put in systems. And today the dormitories, migrant workers who are staying in dormitories, they have a insurance package, right? So any medical treatments that they seek, firstly, they have a medical clinic on site now for the big centers. And the consult fees are just $1 or $2, right? So what happens is that they make the employers pay for this, right? So everybody pays like $30 or something, and then everybody enjoys this service at a subsidized price. So, it's good that something changed, but it also took a pandemic to change things. So, I think it just shows that sometimes there are a lot of all these latent problems that sometimes people don't pay enough attention to. And that's also for us, right, as advocates. How can we use advocacy as a tool to bring these stories, bring these problems to light? Yeah, thank you.
I think that same story about chronic illness also struck me the most, because I know the author personally, and she tells it in a very personal way. And she described how, as a survivor of multiple chronic diseases, then she was not seen as, this thing about when the pandemic, that's essential services, and there was non-essential services. So she was cut from those services, and she got relapses, and then it's just got really ugly. And also isolation that also contributes to the relapses, because autoimmune work with stress and everything like that. But also there's a particular one here. This one is about access to mental health care in rural Indonesia. And that's one of the things that is not seen as essential, even when you have a literal mental health crisis. So yeah, like Clive said, it took us really a pandemic to open the Pandora box. It has always been there. And I also have a lingering question. Do we learn from it? Or at least does the system learn from it and try to see something is not right? It's something that I also still struggle with.
For Myanmar, we have different pandemic, and then part of it is before the coup, and that response is different. And we also have a very massive wave during the coup. So that caused a lot of people dying because we couldn't go. So before the coup, how we did it was in Myanmar, kind of we're whenever the pandemic happened, this kind of we need this protected the hand sanitizer, face mask, and everything. But we also have to think about the minimum wage of the people. Sometimes those are extra costs for certain people to have it and to do it. And also the housing. A lot of the people in Myanmar, the housing structure is pretty crowded, and we don't have enough space to have this 6 feet apart. And that kind of those are a lot of other issue. And for me, it feel like pandemic feel like years ago, because we have crisis over crisis in Myanmar, even everyday crisis. So pandemic since so far. But one thing is it's a lot of the major issue on top of the health issue during the pandemic time was the social stigma, because the way we don't have this proper surveillance system, we do the community CCTV, like auntie CCTV. So the aunties in your neighbor will be like, okay, this person coming back from foreign country, this person got the COVID, and then they have been informed, and then they have this like all the white gowns people gonna come and pick up. So when they do, they will lock down the whole building and everything. So you became like the burden to your neighbor. Even if you come back, your neighbor hates you, like, oh, because of you, like, you know, everybody have to do. So when people, even though people get COVID, they wouldn't say it because they were so scared that they don't want to be targeted by their society. So that is, that's a problem. And the other thing is, one funny thing is like some people that time, people lost job, they don't have money. So they would sign up themselves to the quarantine center so that they can get free meal. So those are a lot of other things happening that time. And our pandemic is more like community led and also volunteer based. And people have been doing that. Was before the coup, and during the coup, there was nobody to support, and we have to queue up for oxygen tank for like since 4 a.m. in the morning. And then there's also like pushing together, and then you queue up for like from 4 a.m. until 10 a.m. to get the oxygen tank, like big tank, because the state doesn't really provide anymore. And then the military would come and grab those, steal those like the oxygen mask. So, and also there was a power cut. People dying because there was a power cut on and off. So like the hospital, the oxygen is broken and people die. And until today, we don't even know what's the cause of that wave. So yeah, a lot of people die, but a lot of system in Myanmar is a community self-help, and we have pretty strong volunteer system, which at some point I think it's a good lesson learned, like things that we can share to the other country, how we have mobilized the community pandemic solution. That is a good solution, but now that all the crisis and everything, we can't talk about this. So yeah, that's what I wanted to share.
Thank you very much, kind audience, as well as our panelists. And we'll take a photo, Vanessa, just of the panelists and then with everyone. Is that the plan? Okay.
Sure. So, okay. All right. A big round of applause, I guess, for everyone. Thank you so much for being here today, and that was a fruitful conversation. I'm sure everyone is excited to read the book as well. The book is available here for donation of 300 baht. Is that correct? Yes, we have a few copies available here. If you would like to help support with the donation going toward a good cause, you can do so. We also have some snacks and fruits over there, and a free space here for networking and chit-chatting, maybe some other questions, some things that you would like to get connect with other people. On behalf of Junction team and staff, we are grateful to have you here, and we rely on your support to keep our space running and going. So thank you so much again for being here, and we hope you guys come back sometime soon. For today, thank you.
Thank you for hosting us. Thank you for coming.